I'm going to talk about bleeding, which can be classified as internal or external. Severe bleeding, which is a major cause of shock, is called hemorrhaging. The body has some natural responses to bleeding, vasoconstriction and clotting. So say this is a normal size blood vessel, and blood is able to go through the blood vessel. But if you are bleeding, your body is going to vasoconstrict the blood vessel, make it smaller, so that less blood is able to get through. Bleeding is evaluated by the speed the blood loss and the amount of blood lost. So different amounts are considered dangerous depending on the age of the patient. For adults, losing 1,000 cc's, which is equal to 1 liter, is considered dangerous. For children, 500 cc's, so half a liter. And for infants, 150 cc's. I'm going to go over different types of bleeding. I'm going to start with atrial bleeding, which is bleeding from an artery. It's characterized by bright red blood. That is because arteries usually carry oxygen-rich blood. And a rapid profuse rate that spurts with each heartbeat. As the patient's systolic blood pressure drops, the strength of these spurts decreases. So think about this. Systolic blood pressure is the pressure created when blood is forced into the arteries. So arterial bleeding, bright red blood, spurts with each heartbeat. The spurts decrease as systolic blood pressure drops. So venous bleeding is bleeding from a vein. It's dark red to maroon because veins usually carry oxygen-poor blood that's full of waste. There's a slow, steady rate. Now, veins return blood to the heart under low pressure. And this may be lower than the atmosphere pressure. So debris and air can be sucked in. If air is sucked in, it can lead to an embolism that can go to the heart, the lungs, or the brain. And this is a problem in large bleeding veins. For example, the large jugular vein in the neck. You gotta be careful for a sucking wound that's going to suck in debris. And that's something to look out for, bleeding from a vein. Next, I'm going to talk about capillary bleeding. And capillary bleeding is bleeding from a capillary. It's in between bright to dark red and has a slow kind of oozing rate. For example, the kind of bleeding from a scratch or a scrape where you get the little pinpoint dots of blood. Capillary bleeding, because they're so small, capillary bleeding often clots spontaneously. So you usually don't have to do anything for that. Other types of bleeding to be aware of: epistaxis is a nosebleed. So if you have a patient that has a nosebleed, have them sit down and lean forward. You don't want them to put their head back, because then the blood can pool in the back of their throat and compromise their airway. If you need to, if the airway is compromised by the bleeding, you can put them in recovery position. Also, you can apply direct pressure to the fleshy part around the nostrils. So apply the direct pressure to the fleshy part around the nostrils. Bleeding from body orifices, for example, blood or cerebrospinal fluid coming from the ears, so body orifices. This could be due to a head injury that causes increased pressure in the skull, which is forcing the fluid out. Do not attempt to stop the drainage, and do not apply pressure. Instead, just allow the drainage. So that is for bleeding from body orifices, or cerebrospinal fluid, CSF, from body orifices. Gastrointestinal bleedings covered in the abdominal video, but I'll go over it briefly again. The abdomen may feel tender, rigid, or be distended. And the patient may have vomit that looks like coffee grind. Other complications could be dark, tarry, or dark red stools. Now, some medications can affect bleeding, especially anticoagulants that are commonly prescribed to patients with a history of stroke, heart attack, or irregular heartbeat, atrial fibrillation, or artificial heart valves. Patient says that they have had one of these conditions in the past and have been prescribed anticoagulant medication. You got to keep that in mind, because it can thin the blood or prevent it from clotting and lead to the patient bleeding more. Direct pressure is the most effective way to control bleeding. If the bleeding is in the arm and it's not well controlled, you can't stop it, for example, you can try to press on the brachial artery to assist in reducing the bleeding. Other things that you can do are use homeostatic agents placed into the wound, which trap the red blood cells. Cold application to minimize swelling and reduce pain and constrict blood vessels. But don't directly put ice on the wound. You got to wrap it in a towel, and don't apply it longer than 20 minutes. If the dressing that you're using, that you're putting direct pressure on, becomes oversaturated, then just overlap. Do not remove the dressing. You want to overlap it. You can apply a tourniquet to limbs if necessary, but do not apply it over a joint. For example, don't apply it over the knee or the elbow. If you do use a tourniquet, place it 2 inches above the bleeding wound. It should be between the wound and the heart. Make sure that you attach a notation to the patient specifying that you use the tourniquet, and also make sure that you notify the hospital or the receiving facility. It's very important that they're aware the patient has a tourniquet on. Splinting for bleeding, for example, bleeding from musculoskeletal injuries, you can use an inflatable air splint. This is only used if there's no suspected bone injury. because they apply pressure. Using air splints, most effective for venous and capillary bleeding, so bleeding from a vein or capillary, not from artery bleeding. And finally, a PASG pneumatic anti-shock garment. Only use that if it's in the protocol, and this controls lower extremity bleeding through direct pressure and internal bleeding in the pelvic and abdominal cavities through indirect pressure. You never use this for chest wounds, and you never only put it over the abdomen. You have to put it over the lower body. That concludes this video on bleeding.